We have got a 9.68% patient, and during refilling of the kerosene oil lamp, we got 9.68%, and during cooking the burn occurred 12.9%, and maximum cases 67.74% occurred during load shedding incidentally when working side by the TV or during carrying the lamps or during sleeping or praying. This was another patient. And in case of the hospital stay duration, we have studied for 1 into 12 weeks. We have seen maximum stay in hospital is about 6 weeks, and 32.26% stayed in hospital for 6 weeks. We have seen that about 64% are taken emergency burn resuscitation, and about 45% from in this hospital, and 19% from outside of this hospital, and 36% are not taken any emergency resuscitation. And among them, the type of the treatment was 80.6% was spirit thickness fingerprint done, and 6.45% needed facial and 6.45% needed debridement. 19.3% treated conservatively by regular dressing. And this is the picture from patient. During 6 years, had the 38% burn and healed by regular dressing followed by spirit thickness skin cut. And morbidity and mortality, we have seen that 12.9% had the hydrotropic scar, and 3.23% developed post-bone scar contraction, and 12.9% were expired. This is a picture of the hydrotropic scar. There would be the full body burn patient. And at last, I think that more study regarding the full body burn is needed. And for prevention of the full body burn, we can use the cover of the lamp. And last of all, we need more consciousness about the prevention of the burn. Thank you all.
Thank you, Dr. Limon. Question and answer session.
I want to add some information to your study. It's very difficult to ban Kupibati because when we are promoting high-failing state of Kupibati, the major area is that Kupibati they use about 50%. They like to use in the kitchen to see the thing in their cooking pot, and they used to use the kerosene when they ignition their cooker. So these are the when actually we promote that this is safer kerosene lamp, please use it. They ask that how can we use these things. So it should be another understanding that Kupibati, and my nested case control study shows that actually the Kupibati when Kupibati used in only kitchen and Kupibati used kitchen and other rooms, it is significant safer actually the Kupibati used in the kitchen. So in prevention strategy, maybe it could be another say that please, whether it is not possible to discard this, please keep it in the kitchen. Then it is also safer. It has significant safety. Thank you.
Thank you, Dr. Nice.
Like Shoba's presentation, you showed something hanging like this in a bucket of that could be.
So our problem is they use Kupibati to see something in the cooking pot.
Not only that, in the roadside.
Next speaker is Dr. Nathan West. Dr. Obi Kumar is not present, is absent. So next speaker will be Nathan West.
I'd just like to say thank you to everyone here in Bangladesh for hosting me and the rest of the interns team and being extremely kind during our visit. So I'm going to talk to you today about my experiences so far as a medical student. Just to give you some background, I'm a medical student in Swansea, which is in the UK, at the hospital where Dr. Tom Pottergar works. And I've got one more year left to go until I qualify. So I'm fairly new to the whole burn care world. And my first experiences really showed that burns are quite distressing injuries. I was very unsure where to start. I was unsure how to treat people. And certainly in the developing countries I've been to and seen burn care, I see that you often have overwhelming numbers of patients, minimal resources, and I thought to myself there must be much easier areas of medicine to work in. So in the UK, you can see this picture here. This is the Morrison Hospital Burns Unit, outside of it. We've got a very low incidence and prevalence of burns compared to you, and we're very fortunate to have highly specialist regional burn centres. We've got very large amounts of resources there, both in terms of the numbers of staff, the drugs we can use, and the types of facilities we have. So of course we have low mortality and morbidity, and we get very good outcomes. But that's not that hard to do with the kind of resources we have. And so many of our patients can usually function in society. The low and middle income countries that I've been to have quite a stark contrast. The top picture there you can see is of the Queen Victoria Hospital in Gambia, which was my first developing world burns experience in 2008. And I'm sure all of you will recognise the hospital in the lower picture. I've obviously seen that you have very high incidence and prevalence of burns, and you have some specialist services, but often there are none. You've got much lower resources, and you have much higher mortality and morbidity, which of course in many circumstances leads to poor outcomes, and it can be very difficult for your patients to function in society. So medical students get involved with interburns, and as Dr. Pottergar said earlier, the TER of interburns stands for training, education and research. So the ways we get involved are we assist in various training programs, and you may recognise the person lying down underneath the red arrow. That's me assisting in a training program. We also get involved in